PK Capti say.
Ravikanth sir.
Yeah.
We are good to start, sir.
Yeah. Good evening, everyone. Welcome to this webinar of lung transplant. Today, moderators is Dr. Murali Krishna. He's a senior consultant cardiac anesthetist from MGM Hospital, having a great experience in transplants, LVADs, heart lung transplants. A pioneer by himself and a very hardworking gentleman. I welcome you, sir, for moderating the session. I also welcome consultant Vikram Naidu, who joined us and has been a very helping hand and enthusiastic and hardworking guy, who's going to present a topic called anesthesia in lung transplant, tips and tricks for lung transplant from experts. Over to you, Vikram. All the best. Do well.
Thank you. Just a minute, sir. Yeah. So good evening, one and all. Today, my topic of discussion would be anesthetic management of a patient posted for lung transplantation surgery. Good evening, Murali sir. Good evening, Ravi sir. Thank you for joining us, sir. And so I'm Dr. Vikram Naidu. I'm a consultant cardiac anesthetist at Yashoda Hospital, Hyderabad, in the team of cardiac surgery and heart and lung transplantation. So coming to the starting, as you all know, lung transplant represents an ultimate therapy for patients with the end-stage lung disease. And in many ways, it can be one of the most challenging surgical procedures to perform. So from the time first lung transplant was performed in 1963 by Dr. James Hardy, a careful, meticulous, and a well-coordinated anesthetic care has had to support the surgeon in order to provide this life-saving procedure to many patients. So, preoperative considerations in a patient who is posted for lung transplant includes the respiratory assessment of the patient, like determining the type of the lung disease, whether it can be an obstructive lung disease, a restrictive lung disease, or a patient with a primary pulmonary hypertension, and a complete assessment of the cardiovascular disease, which might include ischemic heart disease and patient having pulmonary hypertension and other issues like RV dysfunction and progression of TR. And the functional status of the patient, rehabilitation and nutrition, sarcopenia and obesity have to be considered. A thorough airway assessment has to be done, which includes assessment of the Mallampati scoring and assessment of the cervical spine and mouth opening, which might guide us to manage the airway during the procedure. So once the patient is being posted for a lung transplant and once the team has decided to harvest the organs, the particular recipient is being called according to the patient's body weight, which the donor is available, and the height, and various other criteria like the chest CT scan and bronchoscopy are being performed in the preoperative phase to determine which lungs are appropriate for the particular patient. So the patient is being called the day of surgery, and a thorough consent is taken for anesthesia, which includes the potential perioperative risk during the surgery and the need for prolonged ICU stay and the potential need for extracorporeal life support like a VV ECMO, and options for post-operative analgesia and post-operative rehabilitation has to be discussed. An informed written consent has to be taken before the patient is being wheeled in for a lung transplantation surgery. Okay, so now once the patient is being wheeled into the operating room, induction of anesthesia is to be started. So all patients who are posted for lung transplant surgeries are considered to have extreme cardiopulmonary instability and prone to hypotension during induction. The full theater team should be present, including the surgeon. Perfusionist should be readily available. So a protocol which we follow is initially we wheel in the patient and connect all the routine multipara monitoring, which include ECG, NIBP, and saturation probe. And preferably vascular access is taken under local anesthesia with mild sedation, which might include fentanyl or midazolam, preferably with a USG guidance. So what protocol we follow at our institute is we take a left interjugular vein for inotropic support and fluid management, and right interjugular vein to guide in the PA catheter, and a right femoral vein and femoral artery is taken for arterial monitoring. So additional monitoring in a patient for lung transplants include a PA catheter, a continuous cardiac output monitor, and a intraoperative transesophageal echocardiography. So induction of anesthesia, the choice of anesthetic agents can be opioid, hypnotic agents, barbiturates, and benzodiazepines. But any anesthetic agent given in a patient who is having end-stage lung disease, always be remembered that the patients are very, very prone to develop severe hypotension. So it has to be administered very slowly. And at our institute, we follow high-dose opioid induction as the choice of induction for lung transplant. So things to avoid is you should avoid aggressive bag mask ventilation and hypoxia and hypocarbia, as all these can exacerbate the RV dysfunction, which might lead to RV failure. So usually one lung ventilation is required because lung isolation is mandatory during lung transplantation surgery. So we use a bronchoscope and then confirm the position of the WMN tube, preferably left-sided WMN tube, appropriate to the patient's height and patient's weight is being chosen. And the trial of one lung ventilation should be performed. The patients who are having obstructive COPD kind of a lung picture, usually we use tidal volumes of 4 to 5 ml per kg, and patients with restrictive lung disorders, a lower tidal volume of 3 to 4 ml per kg with a higher ventilated rate is being preferred. So antimicrobial prophylaxis and immunosuppressive therapies are administered before skin incision and again at specific times during the case according to the institution protocol. We follow antimicrobial prophylaxis 1 hour prior to the skin incision and immunosuppressive therapy, which includes mycophenolate mofetil and methylprednisolone and tacrolimus during induction. So Indrop TE plays a vital role during the perioperative management of the patient post of a surgery. So it can provide necessary information about the RV function, the severity of the tricuspid regurgitation, the volume status of the patient, and presence of any intravascular air or thrombus, and the patency of the pulmonary veins and patency of the pulmonary arteries. So all this information should be compared in the post-operative phase once the lungs has been implanted. Once the new lungs on the have been harvested and been implanted, then the change in hemodynamics, the RV function, the volume status of the patient, and the patency of the pulmonary vein should be compared. So this is a TE image showing the midi-esophageal 4 chamber, showing all the 4 chambers. So the diameter of the RV, the size of the RV should be taken both in the 4th chamber and in the mid-papillary view. And the flow across the pulmonary vein, like as you see in the right bottom image, which shows the left upper pulmonary vein, which is showing no turbulence across the red color image, showing no turbulence across the left upper pulmonary vein, and the gradient should be measured across the pulmonary vein. So coming to the surgical procedure, so bilateral lung transplant is performed as a sequential procedure. So either it can be performed to bilateral anterior thoracotomies or a clamshell incision is being given depending on the surgical requirement. So once both the pneumonectomies are being performed. Then trial clamping of the PA is performed on the required side. Usually a VQ scan is done to determine which side the perfusion is minimal. So the procedure is started. So usually the right-sided pneumonectomy is initially performed, and the right side we commence to proceed and start the right side graft first. So trial clamping of the PA is performed, the patient hemodynamic assist clinically with the transesophageal and with the TE. So any progressive hypotension or any acidosis or a rising lactates or hypoxia during the pulmonary dissection might necessitate the initiation of ECLS. So usually preferred mode of ECLS is central VA ECMO, wherein ascending aorta is being cannulated and the bicaval cannulation for the RA and IVC. So go on on a central VA ECMO and proceed to perform the procedure. The transplant procedure, first the native lung, the right lung preferably is excised and the first allograft is reperfused. Then the second native lung is excised and following the second lung is implanted. So each allograft, there are 3 anastomosis which include a bronchial, pulmonary artery and a pulmonary vein anastomosis. So accordingly it is done. So now coming to the major issue in a patient who is posted for lung transplant in surgery. So this is reperfusion injury. The whole world, everyone starts discussing, the only thing is reperfusion injury. Once you're out through this phase, the major surgical exercise and everything is a success once we are done through this. So reperfusion predisposes to allograft pulmonary edema and can cause marked hypotension once the clamp is open. So there should be a clear communication between the anesthesiologist, the perfusionist, and the surgeon during this procedure. So the technique he followed here is the PA clamp is released very slowly to proceed with de-airing and to allow perfusion of the graft. So over a period of 10 to 15 minutes, that is done to minimize the risk of allograft injury and to avoid hypotension. But still, because it's a vast organ, so we are predisposed to having some amount of hypotension once the allograft is perfused, and they should be ready for reperfusion by increasing the rate of vasoactive agents like noradrenaline or adrenaline and giving boluses of fluid and calcium necessarily. So after reperfusion of the first allograft, a trial of 1 lung ventilation of the newly implanted lung is undertaken. So appropriate ventilator settings include a low tidal volume of 3 to 4 ml per kg with a PEEP of 8 to 10 centimeters of water and preferably low FiO2, that is 0.3, and the peak inspiratory pressure should be as low as possible, achieving a saturation of above 90. You don't need to target 100% because higher FiO2s are more toxic and can cause allograft dysfunction. So FiO2 is as low as 30% with a PAP as low as possible to achieve a saturation of 90% should be targeted. So after the allograft implantation, once the right is over, then the left pneumonectomy is being performed. Then the left allograft is being implanted. Then the WMN tube is immediately exchanged to a single lumen tube and the thorough bronchoscopy is done. So bronchoscopy, this is a bronchoscopic image which is showing the bronchial anastomosis on the right hand side. So once the bronchial anastomosis is being visualized and thorough suction of all the secretions and blood has to be done, then we change the DLT to an SLT and the bronchoscopy is being done. So once we are commenced with 2 lungs implantation, the ideal 2 lung ventilation settings which include a tidal volume of 4 to 6 ml per kg, a peak inspiratory pressure of less than 25 centimeters with a PEEP of 8 to 10 centimeters of water. So targeting a lower FiO2 requirement of less than 0.5. Ideally, we start here with 0.3, targeting a saturation of above 90 and aiming a pH of more than 7.2. So a mild fluid restriction is always advised to minimize the risk of PGD. So look out for any other issues, any mechanical cause of obstruction like an endotracheal tube block or a kink, and any other cause of high PEEP, and do a thorough suctioning. Bronchoscopic guided is ideally advised. So thorough suctioning of blood and secretions and a gentle recruitment to recruit all the lung lobes. So with the PIP of 30 centimeters for 30 seconds may be helpful. So once again, a transesophageal echocardiography is very important. And this time you should inspect what all should be inspected is the RV function, the P anastomotic site, the pulmonary vein anastomosis, and the pulmonary vein anastomosis should be more than 5 millimeter, and the gradient across should be less than 10 centimeters, and any visible edema fluid in the airway strongly suggests PGD or a pulmonary vein obstruction. So ISHLD grades the PGD in grade 0, 1, 2, and 3. So 0 is a PaA to FiO2 ratio of more than 300, and 1 with the presence of pulmonary edema. Maybe we can't get an X-ray done at this point, but we can see some frothing out through the endotracheal tube. And even if the PaO2 FiO2 less than, that is around 200 to 300 with the present pulmonary edema, it's graded as grade 2. And severe PGD when the PaO2 FiO2 is less than 200 with presence of pulmonary edema. So ISHLD recommends the usage of mechanical ECLS like VV or VA ECMO if the grade of PGD is more than 3. So if the PGD is suspected, a trial of INO is being given with a 10 ppm. So persistent hypoxia with a FiO2 of 0.7 and saturating less than 90% should prompt consideration of a VV ECMO. So during this period, once the allograft implantation is done, you can expect some hemodynamic instability. So the most common cause in this situation would be RV dysfunction, hypovolemia, arrhythmias, vasoplegia, tamponade, and increased interthoracic pressure. So trying to deal with individual problems. So RV dysfunction usually diagnosed with a high CVP and a transesophageal imaging showing a dilated RV with the septum bulging towards the left-hand side, and a dilated RA with the septum dilating towards the left-hand side. So this immediately can be managed with the use of inotropic supports like milrinone and minimal dose of noradrenaline. And hypovolemia can be corrected by giving blood and volume. Arrhythmias can be appropriately managed by checking the ABGs serially, and cardiac tamponade can be surgically managed, and increased interthoracic pressure should be checked at the surgical site. So if there is any persistent hemodynamic instability, there is a MAP of less than 65 with a cardiac index of less than 2 liters, despite appropriate vasopressor, particularly vascular hypoxia, and it is always indicated and advised to go on a VA ECMO. So intraoptech may be helpful in the management of bleeding and trailing the administration of blood and blood products. And after a thorough hemostasis and chest closure, the patient is transferred to the ICU. So thank you very much. And these are a few of our success stories. Thank you.
Thank you, Vikram. Thanks a lot. It's a wonderful presentation. Any questions? Murali sir?
Good evening, Andy.
Yeah. Any expert opinions regarding lung transplant, how you handle and how you do it in like toughest cases? How do you manage?
No, it was a compact and concise presentation. Whatever needed, he has covered everything. But just to add, or just to cover things, if we start from the beginning, this is like this. If you look at the current guidelines or the recommendations for anesthesia management of lung transplantation, what it clearly says is, even if you are just a simple hardcore anesthetist who is confined to theater also, these are the cases where we have to look at all the thing in detail. That is preoperative, intraoperative, and post-operative care. So that is first and foremost. At some places it may happen the critical care and anesthesia teams are different. But for this, the recommendation stands clear that the anesthetist should know right from the beginning because of the variability these cases have. From the time they first see to the time you operate, there'll be a lot of difference in their strictness and multiple factors. That's one. And whatever we do in theater has a very big holding on the post-operative behavior of this patient. So to get a feedback, they recommend that we should be involved continuously throughout. That's one. Then second, if you look at the anesthetic targets also, that is recommended. I mean, it is not like any other cases where they say, okay, this is your choice of relaxant and all. It clearly says only two things: do whatever we can to preserve the allograft function or prevent the PGD and see that there is no other second organ damage. That is very simple and clear word. So entire focus of the surgery or the anesthetic management is to see that the allograft function is better. That's second. And to start with, we should know, like Vikram said, a lot of things about the recipient. Even if that anesthetist in that particular case is looking at the case first time when it comes to the paper, starting from how sick he is, whether it is just on oxygen or how badly he progressed, only oxygen or ventilator, NIV, or to the extent that he has gone on ECMO, what is his preoperative status, sensitization status. All these things will be discussed well in detail, but as an anesthetist, we should know all these things before to get a stratification of the patient. So similarly, the CAT study and the cardiac function, RV function is very important to know how it will fare or what the patient needs. Along that, equally important is your diastolic function of the left ventricle, because a lot of these patients, especially the pulmonary hypertension and the chronic ILDs, who are having from the young age, they will be chronically underfilled. So once we transplant, they'll have a diastolic dysfunction, which can lead to pulmonary edema. It is a big trouble post-operatively. So that's one thing. Coronary status, all these we should know in detail. Similarly, from the donor end also, we should get all the full inputs. What is the size matching? Is this a good organ or borderline organ in briefly? If it is borderline, in what aspect this is borderline? Is it a borderline because of the PF ratio, borderline because of the age, or a smoker? Because your entire intra-op and post-op course, these are all the factors that are going to influence, so you can titrate things accordingly. Then always, like any other major case, the discussion with the surgeon well before the case starts helps us. Like, what is your strategy? How are we going to go with the sequential anastomosis? What are your thresholds for different conversions? Whether you're starting with an extracorporeal circulation or off pump, then extracorporeal, then what is your choice of extracorporeal? What are your transfusion thresholds? All these things we should have a clear discussion. So if we land up in a situation in paper, we'll be able to have a quick solution to that. And as I described, it varies with the approach for that particular procedure. If it is an off pump, they have to be gradually clamp released, and especially during the anastomosis time, they can be quite unstable. That may require us aggressive management or a quick support with ECMO. And if one comes to the extracorporeal support, ECMO is the preferred one, but still in some cases CPB is used where you have a lot of bleeding. So if we have ECMO, there how would you handle the bleeding better, and a cell saver may be of a help. Along with that, the perfusionist should be quick and ready to convert it into a CPB in case it happens that there is an emergency where you can't run the ECMO. A common example may be if you have a large venous airlock which is coming from the venous side. So all these things should be well prepared in advance, and entire team should have like a drill kind of thing in mind, which will quickly translate into an action without any consequences kind of thing. And CPB will be easy to do, but again, that has issues in terms of graft dysfunction, bleeding, transfusions, all these things. ECMO, we need to keep a close watch on the flows, especially when they're retracting and doing the left lung. It can very well happen. A lot of times the flow fluctuations can happen, which can reflect as a second organ injury in the post-operative period. Gradual reperfusion is the key to the graft. If it is a off-pump case, then slow clamp release, and if it is on extracorporeal circulation, gradually loading the lung is the one that you go on. You slowly go down on your ECMO support and see how is the patient behaving, with a very keen watch on the pulmonary pressures to make sure that pulmonary pressures doesn't go above the normal levels all the time. And any pulmonary edema, you aggressively go for your supportive measures. And the graft dysfunction is your main worry. You don't let the graft suffer with high ventilator settings or anything. The slightest doubt you have, you try to support it in some way or other. A short-term support in theater, wait for 1 or 2 hours, or if required, a VV ECMO, or if the ILV diastolic dysfunction, if their PA pressures are high, a combination of VAV or VA ECMO. And finally, post-operatively, your major concern in these patients next to graft dysfunction is the bleeding, especially the one who are preoperatively on antiplatelets if they're associated CAD, or someone who is on ECMO for longer time. It will be quite challenging. So aggressive management right from beginning. Right from beginning means once this donor is confirmed, immediately you try to do a tech and try to correct whatever you can if there are gross deficits there. Then again, once the graft is processed, you may have to kind of aggressively handle the coagulation to make sure that the patient's bleeding is under control as quickly as possible. These are the gross things what I can think of, but otherwise a very good presentation.
Thank you, sir.
One question, sir. What is your transfusion trigger for your patients on ECMO, and when you manage them on ECMO? What is the normal hemoglobin you manage them with, like when you are doing a central ECMO?
Central ECMO, if you're talking of pre-ECMO 8.
Okay. And normally, what is like the transfusion triggers? Like what is the normal blood loss and what is the transfusion? How many normally do it? How many you do it?
It all, as I said, it all depends upon case to case basis. On one side, you have an extreme patients who are on ECMO for 40 days, 50 days, who just bleed right from the beginning to the end. There, though the whole concept of lung transplant is like try to minimize your transfusions, you will be helpless there. It certainly needs some transfusions of products, especially and blood to sustain the hemoglobin before you have clots formed in the post-operative period. The trouble comes if you have an associated graft dysfunction or some other problem where they need an extracorporeal support. So that adds to the trouble with the bleeding. They are the cases which are toughest, like in the acute COVID time, who had that severe inflammatory reaction or who has gone through that septic episodes when they come to surgery. They are the ones toughest. Otherwise, a simple case preoperatively, not an extracorporeal support. It all depends upon the patient's preoperative hemoglobin and how they behave in the theater. A lot of times you see them preoperatively having muscle loss, nutritional losses, at least in spite of putting them pre-op rehabilitation. Usually patients wait 4 to 6 weeks at least before they get an organ. In that time, whatever you try to build up, it may happen in some of them because of the underlying tachypnea or lung disease. One, nutrition intake will be poor, and second, the catabolism will also be so high that they won't be able to build up. In those cases, certainly, you end up in transfusing plaques. If you read the Western literature, like what comes from Vienna and all, they say that very little one blood or even not blood and all. Practically, Indian situation, I don't think that's a common or norm. A lot of times we end up in transfusing.
And do you consider putting VV ECMO prior in a patient, in a sick patients, prior to induction, sir? Any patients?
No.
Okay.
About induction, what is important is to get an idea about the underlying etiology. They have etiology-based specific trouble. I mean, anyone can trouble, there is no doubt about that. If you are dealing an ILD, especially a very bad ILD, who is preoperatively quite tachypnic, you are thinking that you may do an ECMO. I mean, shortly he will go on ECMO, but luckily he gets an organ before he goes on ECMO. It may very well happen once you intubate, you may not be able to ventilate that. So a higher threshold, anyhow you're going to discard that lung, you may have to ventilate them with higher airway pressures. Usually, if required, get an ICU ventilator and ventilate, because OP ventilator's capability will be limited. They will be delivering lesser tidal volume for the same pressures. ILDs will be prepared for that. And second, you'll be ready to quickly go on pump if required that cases. Similarly, any patient with a very large cavity in the preoperative CT, like a huge bulla there, suddenly they can go into COPD patients, or this can have a large BP of induction and mechanical ventilation. They again present with a tension pneumo kind of picture. So that we should have in mind and be ready. Similarly, if you have a bronchiectasis, they may not have that bad cough and secretions preoperatively, but once we intubate, you see that the suction just keeps coming, pus kind of thing. And pulmonary hypertension, especially the pulmonary hypertensions where RV is borderline and all, they're at the highest risk of arrest at the time of election. So all this case specific, I mean, anyone can trouble, there is no doubt, but this case specifically, we should have in mind. And also a lot of these patients are dehydrated as a part of your lung management, though they may not have RV failure. Also diuretics, a lot of times the residue will be totally dehydrated. Your lines won't be so easy because the vein will be just keep collapsing. So always ultrasound guidance helps us, especially these patients, since you're looking at post-operatively supporting them with ECMO if required. So line should be clean and ultrasound guided by default.
Yeah, absolutely. And what is your induction agents when you face a patient with severe PH? Like you go for an opioid induction or anything else, or anything like?
Opioid with etiolate in a very gradual phasic way.
Okay,
that's the best.
Any role of thoracic epidural you've been using for post-op analgesia, sir?
That is again that's one of the important things we need to discuss with the surgeon preoperatively itself. I mean, what is the surgical plan? What are the chances? I mean, what are the conversion, and when are you going to do that if required, off pump to ECMO to CPB? And what are the lung isolation? What is the surgical incision? So that you can plan your analgesia and have a discussion with the team. Epidural is not something we commonly use because quite commonly we do it on ECMO support by default. But epidural may be quite helpful in these patients because the incision will be quite extensive, especially the clamshell one. But even in those cases, we see that with a couple of IV analgesic drugs, we should be able to maintain that. Opioids and paracetamol, most of the times we should be able to maintain. But certainly epidural will be helpful, provided it fits into that bracket of extracorporeal circulation, anticoagulation, and you are able to do it in that safe window.
Okay, good. Thank you.
As of now, at our center, we are still using going on elective VVA ECMO, sir. That is central VA.
VA. That
So
is by default. Most of the centers to do that. One of the reason is most of your cases become late. You look at your typical textbook criteria for doing off-pump. pH should not be there. There should be reasonable amount of lung function left to sustain ventilation when you're on one
Submission
lung
is
and on.
when you do a half pump, I think your lung perfusion scan matters a lot because you have to do the least lung perfusion and then do the better lung. If not, you have a lot of PGD. And one more thing is post-op, any patient pre-operative evaluation who has a left ventricular dysfunction, then can have a lot of capillary leak because of LV diastolic dysfunction.
That's like this. Yes.
Because that leads to a lot of capillary leak and lung starts. Yeah. That's what.
So active VV ECMO is as of now preferred, sir, in our setup. So because we tend to, because that says it can reduce your chances of PGD and your initiation of second ECMO will be reduced. So what is your
VA ECMO? But most of the times it is VA ECMO only. Because
no,
lot of the
post-op, sir. Once we are done with the surgery, so we are usually leaving them on VV ECMO and trying to see for the next 24 hours and then trying to decannulate rather than just giving a trial of 1 hour and decannulating on table. What does it say on this?
See, that is practiced in literature to the extent that there are some studies, if you see that they put on ECMO, they expedite the patients. They put on ECMO, they expedite the patient. It is like first wean the ventilator, get the ventilator out, and then get the ECMO off. But again, everything has its own plus and minus. How we go with is we try to come off. All cases we try to come off. When you're coming off, you look at your obviously how are your ventilation parameters. Yeah. So you never cross your set limits. Your set limits include your peak pressure or your FiO2 what you're doing. You never cross that. If it is happening that you're crossing that, you immediately you go for a support rather than stressing that organ. So your support, if it is only gas exchange is a problem, obviously go for a VV ECMO. On the other side, if your problem with the hemodynamic, that is especially the pulmonary hypertension, the heart may or may not trouble, but pulmonary hypertension is one of the common cause that may push you for a VA ECMO or a VAV ECMO. So the main challenge comes here there is how do we handle the anticoagulation because of the associated bleeding, whether you're going to reverse your protamine or not reverse your protamine, and or you're just going to wait till the patient's ACT comes down to normal level, and are you going to give heparin in the post-operative period or not totally give it at all or start it after 6 hours. These all a bit complicate the matter. So that is why general choice what we follow is if we try to come off and patient looks stable enough, then that's it. We try to we'll manage it with ventilator only. But if you have any trouble at any point of time, that will be converted to ECMO as it is with the VV or VO. Generally, all patients we have lines taken and kept. The femoral artery, femoral vein, and the neckline obviously will be there. So conversion, even if it is required, it will be quite quick.
And your choice of inotropic agent, sir, once you're then in the reperfusion phase?
It all depends upon what the patient needs. CA catheter is a must, and by default we use a CCOPA catheter. Yeah. So you look at your cardiac output and see what is needed for the patient. Nitric oxide, yes, for all the patients, and it all depends upon what he needs. In some of them, we may be just giving only vasoconstrictors like a Moderator vaso. In some, it may be 2 inotropes. Essentially, you try to target an adequate cardiac index with a lower PVR and an acceptable SVR there.
Sure.
Yeah, we've been using the same continuous cardiac output monitor.
That is best. That will that is best. That will tell us.
And interrupt tech, sir, post-operatively?
Tech, yes, for all cases, tech, yes. Once we give protamine, reverse them, immediately send a tech. And maybe if it's had one after receiving in the ICU also, that will guide you what your patient needs for as a part of products and all.
We are just keeping the patients on VV ECMO because generally we do a VA ECMO on the intraoperative side, and we wait for 1 hour. And the patient is not wean, like we're going to wean from VA ECMO, we convert back into VV ECMO for about 24 hours to 48 hours, and then we remove the according to the ventilator and the PF ratio, we remove the ECMO first. That's what we're doing here.
That's also the described strategy, very well described strategy. You're not going to strain your lung, let it rest. and then slowly kind of this one. Only problem may be bleeding, anticoagulation handling. There'll be the challenges there.
Yeah. We maintain ACT around 160 to 175. Like, that's what we maintain. Like, that's what it is. That's what.
And often it may happen that you may have to keep the chest open for whatever the reason, the bleeding or a size mismatch, especially if you.
What is your experience in size reduction? Like, if you faced any patients with size reduction post-operative PGD and like, having difficulty in weaning from ECMO and this. So.
Sometimes, some while ago, the size reduction used to be done in grossly where there is a gross disparity. But again, there were challenges with it, especially when you resect a large cut of lung that will lead to pulmonary hypertension, which can trouble you after the surgery. So other thing is, if you have a gross size reduction, you just leave the chest open, even on mechanical ventilator, and cover that area well, and then keep it like that. Usually 24 to 48 hours, the lung size comes down. If you take an oversized lung, it may look like it is coming out at the maximum. Only one lobe may fit in, the other lobe totally seems to be coming out. You may see some compression a lot, but that won't be the same after 24, 48 hours. That becomes relatively better, is what it is. Lobectomy or is a volume reduction surgery.
Okay, thank you.
Okay, sir. Thank you.
So,
Questions?
I had a question. So, how is your anticoagulation on ECMO? Like we don't really give a lot of heparin. We give I think 5,000 at the start.
So we are giving around 2,000, sir.
2,000 to 2,500.
Maintain ACT less than around 100 to 200 initially.
Yes, so that's pretty low.
Hello?
So how do you do that? What will be a anticoagulation like? Hello, are you able to hear me? Is it there?
Sir?
I think he lost the connection, sir.
Yeah.
Yes, I could go here only till Balu asking about anticoagulation.
Yeah, so see, we give only some 2,500 heparin on starting in ECMO, and then we maintain the ACT at around 160 to 180. So is your strategy the same or
Same. Around 0.5 to 1 mg per kg is what we give. Rather start with a baseline ACT even before anything, and maintain it less than 200 to 180 around. If you're a VV, VA means up to 220 we go up to. We start a heparin infusion and you keep titrating it based upon that heparin infusion and the ACT levels, which are checked regularly.
Okay. So starting is with 0.5 to 1 mg per
1 mg, small dose only, not big.
Okay, and have you had any microclots in your oxygenator which you had to change in the ICU?
Change in the ICU, I think maybe one case we changed, but grossly in that intraoperative period, it doesn't happen that you need to.
We had that problem for OSTEP. So I was wondering whether we should be giving a higher dose of heparin than the low dose we are using.
Usually, introp usually it will not be much of a problem, but post-op once we shift depends upon what oxygenator you use. Usually we use the ECMO McVeigh long-term oxygenator. That's what we use. And the PLS circuit is what we use, or cardio help in some cases. So that usually tolerates that degree of anticoagulation. But once you shift, you keep a watch on it like any other regular ECMO case. You see your delta P, look at your D dimers, keep a watch visually on the oxygenator, then look at your coagulation profile. One case I remember changing the oxygenator after a day or two, but otherwise it all depends on case to case basis. Some may come for longer time if required. Some of them well before that you take out the ECMO kind of thing.
One question, like what is the reservations on using blood and blood products and FFP and everything in a patient having very bad stuck lung, having a lot of oozing and blood loss?
They require compromising hemodynamics is a equally bigger trouble. I think we should sustain that hemodynamics and means if it requires, we have to give with a clear transfusion thresholds and whatever the tech or the guided products that they require. It's not that we don't give it, especially ECMO cases and all they require.
You use FFP, sir? In the cases?
Yes, we use. FFP means it's like this. You definitely do a tech in these cases, either before you take into theater. Now, the ones I'm saying pre-operative on ECMO for 1 month, 1.5 months, you do a tech. That tech will tell you, and your coagulation profile will tell you what you are dealing in these patients. So then,
and you pre-operative any fibrinogen levels and any using any fibrinogen for this bleeding for patients and also any oral
fibrinogen. Only one patient we used. That's all. That's only recently it is available. So it's only one patient we used.
Okay. Instead of giving an FFP, can we use any PCC concentrate? We have an octoplex sort of like
octoplex also will. Yeah, octoplex also. I mean, we can use that octoplex also. Usually, your INR will be a problem. Like how we do is if someone is waiting for a transplant, and if that particular patient for some reason your heparin, you're not happy with the heparin, either there is a thrombocytopenia or the patient you're not achieving targets, you may shift to bivalirudin. But the moment you have an alert, usually it will be at least 2 alerts from the time you have the first alert to the time it really translates into a transplant. So moment you have an alert, you switch over to heparin. So you'll be able to antagonize it or give an antidote to it more easily. When bival is for longer time, you see that they'll have a changes of the INR. Those patients do require plasma, but otherwise also on ECMO, if they're bleeding post-operatively, if they're especially 30 days, 45 days on ECMO, they do require products. So it's not that we get away without products.
Ravikanth sir just made a small case, sir. Can we present that case, sir?
Sure.
The induction of immunosuppression, sir, your protocols?
Give them myfortic and taxant as soon as your transplant is confirmed. That is either in the ward or ICU, wherever the patient is. Now only steroid. We have used Campat in some cases where it is available. That again is a small number. That will be less than 10. It's very difficult to derive any conclusions based on that. That is based upon a couple of papers which are there in the literature. But if you use Campat, you don't give myfortic, and you come down on steroid very rapidly to very small dose. Otherwise, fractions, steroid and
mycophenolate.
Mycophenolate along with it accent also. The preoperative post-op. Usually, lungs won't have that trouble like cardiorenal in them, so you will be able to give immunosuppression in these patients.
So, is the screen visible, sir?
Yeah.
So this is a 37-year-old male with an interstitial lung disease which was RA associated with a BMI of 32, who was symptomatic for 10 years with cough and shortness of breath and recurrent exacerbation of ILD in the last 1 year. And his baseline oxygen requirement is 10 liters of oxygen and with a limited mobility at home. He has a prior history of OSA, and he is also using night CPAP along with oxygen. And he gives history of recurrent steroid pulses, and last dose of rituximab was given around 6 months back. So in the pre-transplant workup, he's newly diagnosed. He's found to have newly diagnosed diabetic and dyslipidemic. And RFC shows a normal coronaries with raised wedge pressure and normal cardiac index. And PRA class 1 is around 12% and class 2 is 15%, with a SAB of multiple loci in class 1 and class 2, which is sensitized. And the highest MFI was in class 2, which is around 10,000. So, what is the anesthetic concerns in the pre-transplant and especially while inducing to Vikram sir? Because there are many issues with this patient, especially in the pre-transplant and especially in the induction. So, what is your opinion, sir?
So the considering plex during the intra period is still a matter of concern because
No, sir. Only the plex we'll discuss later, sir. About that case only, sir. From anesthetic point of view, sir. Especially
from
with
point
this
of view, as previously discussed in this patient, he would require opioid-based induction, and because otherwise, from the cardiac point of view, his PA prayers are normal. The only thing which is the high risk is a higher requirement of oxygen. So we might expect the patient is being the respiratory condition is very bad. So at this point of view, as discussed in the presentation also, all the lines have to be taken under local anesthesia with ultrasound guidance and slow high dose opioid induction with assistance and to avoid hypotension and hypoxia during the induction phase. So that is the most important thing.
The main goal of the anesthesia is to avoid hypotension, hypercarbon, hypoxia, and we should be competent enough to put the DLT in as fast as possible, so that to avoid that hypoxia as well as any deterioration in this. And one more thing is any other agent like propofol and anything, there would drastic fall of your pulmonary artery pressures immediately. Once the pulmonary artery pressure starts falling down, you really have to be really cautious that okay, a surgeon should be next to you. Go on a VV ECMO immediately or a VA ECMO, because he won't give you time. Once you starts RV dysfunction, everything starts on you won't give time. You'll have a coronary issues and all, because already patients having dyslipidemia, you have to maintain a mean arterial pressure as well as you should know a preoperative. You put in a PA catheter, you can understand what is the PA mean pressures, and according to that, the induction strategy varies. Generally, what we do is as Vicky said, we use we maintain the mean pressure and mean pulmonary pressure, so that there should not be any drastic fall. That's what.
Okay.
And the second part, I think that needs some discussion.
I think to Murali sir, what is a induction agent, and especially with this patient with a high MFI in the single antigen beat, what is your opinion both as regard to induction agent and especially as regard to the plex during the intra-op period, sir?
Induction agent, see, right now we don't have many choices, in the sense whatever the available is now not available. So that leaves us with only 2-3 drugs. One is a steroid. If you leave aside the mycophenolate and tacrolimus, a steroid. The second one is an ATG. ATG we have not used much, but that's something standard and which is described in literature. We have not used it, more like an institutional protocol. We used it long back where the experience was not so happy or great. So then after that we shifted to steroid. And since we are able to manage with steroid, we didn't thought, okay, we need to explore this more or anything. But in some cases, as I said, I think less than 10, we used Campat recently. But that Campat again is usually given once the organ is resurfaced, not immediately. So if you come back to the thing, by default, your choice will be a good dose steroid. If available, go for a Campat. And if you have an opportunity, get a cross match done between because it's only PRA that can only suggest, but not totally certainly point that you can have still a negative cross match with a high PRA also. So if your PRA is still reactive, that leaves you with different choices. One is to turn down the organ and choose another recipient, and probably wait for a donor where you have a PRA which is positive. On the other side, PRA borderline or your recipient is sick, you're not able to get a cross match. In this, I know not PRA, cross match is borderline, and or the recipient is sick where he can't wait for the next organ, or you can get a cross match at all. In that situation, if you have to go ahead, plasma exchange we have done in few cases in theater. You plan it well, take it into the theater, go on pump and do a plasma exchange. Both heart and lung cases who are highly sensitized, you have done plasma exchange in 2 cases.
For the plasma exchange on a VA, we can go on an elective VA ECMO and connect the
Yes, bypass or VA, whatever. If a heart means bypass, this one means on VA.
You can put your CRRT machine, what is available with you, plasma flex vision, and you can do a double volume exchange of plasma, and that is
plasma. You have the plasma exchange filter also available, so we can use that filter and then do that.
You are using any albumin in this one, or using only FFPs?
FFPs, mostly FFPs.
Okay.
So you preferably do after the lungs are implanted, sir, or how do you do it, sir?
No, before.
Before itself, before
Before
both.
itself.
Really,
Yes.
ideally they say that to start immediately after induction and like to continue after this. That's what they do it.
You have to time the case. I mean, of all the factors we take into consideration when you time the case, like a redo, when is your organ coming, all these things you take it. So this is also one of the factors you take in. This needs time, so you try to time it a little early so that before your clamp of adequate exchange has to happen.
They say that before your first clamp is off, you have to finish the size
Exchange, yes.
And when the
Actually,
cross match is negative, sir, like with even when there is high MFI, do you regularly try plexer and just wait for the DSA after day 1 or day 2, or what is your take?
Cross match negative, I don't remember doing that. But
Okay.
yes, we need to keep a close watch on them post-operatively, have them adequately immunosuppressed. Any doubts, think on lines of infection.
Do you do TSA values on day one after transplant, especially when your MFA is high?
Day 1 and all, I don't remember doing.
Like opposing you do an intraplex. Now you have to decide whether you have to go on and do more. So in that situation, do you do a TSA on day 1 and if it's low, you don't do, if it's high, you do, is it useful?
I don't remember practicing it that way. I don't remember doing in any case first day. Similarly, I'm not sure whether something in literature also don't remember reading. But if in these cases you have a very low threshold for biopsy if required. You can get a biopsy report usually within a day that is suggestive of what you are dealing, whether it is a rejection or these things vary. So that will guide you. Anyhow, first day, second day and all, you'll have a very good immunosuppression because what the steroids you loaded them intraoperatively will still be working well. You are in still good dose of steroid. That's almost pulse dose of steroids will be going on first day. So DSA, I don't remember doing any time on day 1. But
So,
any doubt, yes, biopsy.
So you do only an intraplex and stop there. You don't go ahead and then do more.
Introplex, if you have a concern with the graft function, that's when we have to again change. If you don't have a concern with the graft function, which is graft function which is unexplained by some other parameter or some other trouble, that's when I think probably we have to think aggressively, see whether there's a rejection, give again a pulse dose steroid, if you require a plasmapheresis, all these things go for that. Yes, we did plasmapheresis like that aggressively for one patient post-operatively, but I don't remember sending that DSA for that patient post-operatively.
And
On day 1, I mean.
do you repeat your ERA levels for your sensitive patients once in 3 months or once in 6 months? Like, because if they have high sensitive values, do you have any protocol to repeat them after 4 months, sir?
Most of them before that will get an organ. Most of them 4 months usually. Indians won't wait. But if they come from some worked up elsewhere long back and all, yes, it will be repeated. Someone worked up somewhere and after they will not follow for long time and then they come to your center for a transplant right now. That's when, yes, you will consider.
Ravi sir, any other queries, sir?
So that's what, as you're talking about intraoperative flex, we can do we can start it like in 1 hour prior to the induction of the anesthesia. You can put your double lumen dialysis catheter in the patient and can do a double volume plasma exchange using your FFPs, FFP and albumin, because you just can't give only albumin, because if you use only albumin, you're losing your coagulation factors, and these patients will tend to bleed a lot in intraoperatively if you do a plasmapheresis only with albumin. So it's ideally used half of albumin and half FFP for these patients when you do a plasma flex for these patients. To start 1 hour before and make sure that you do a double volume exchange prior to the cross clamp is released.
Sir, I think there is a questions from someone, sir, about the bivalirudin infusion, sir.
Yeah, biliverdin generally we start like, when you have an indication, when you compare it to using a heparin for long-term infusions, and if you have hit antibodies a positive, we start biliverdin. Biliverdin is a very short-acting actually. Once you stop it, and when we use biliverdin, we start seeing APTT values. We manage APTT. We have to maintain APTT around 50 to above 50, 45 to 50, 60, like that we keep it on VV ECMO. And it's very short acting. Once you stop, the action comes down in hardly in 2 to 3 hours. The dose is around 0.25 to point something like that. We give a bolus dose followed by infusion, continuous infusion.
But not at least in the initial phase when you are starting a transplant. Maybe as Murali sir mentioned, if the patient has a history of HIT.
It's the best agent for managing.
So in that cases we can use it, not as a routine regular. Murali
When
sir,
you have long-term with ECMO, you can start heparin and discontinue, use biliverdin. Again, when you have a transplant, convert back into heparin and use it. That's better.
Bala sir, any other queries, sir?
So Murali, see this graph volume reduction. Do you really see size matching, or just take every lung and just ice it accordingly? What's your usual plan?
It is not practice, Balu. It was like initially in few cases when it was done, it was not a good experience. In the sense the PS goes up probably because you decrease the pulmonary vascular bed and you're flowing the entire cardiac output to that decreased vascular bed. So that's why the PS go up and they tend to have more pulmonary. So by default, it is not practice. An element of size mismatch, we take it. It's not that we strictly go by 0.8 to 1.2. Size mismatch is taken. If it is very gross, like 50-60% and all, it is not taken unless you are really forced to take in that sick recipient or
we usually accept something like 2 centimeter, 2 centimeter, max 3 centimeter. Beyond that, I don't think we accept. So we never have had a high PA pressure because of a reduction.
That's what. Yes.
2 centimeter, and I think is 2 or 3.
This problem occurred when we took in some recipients like the typical ILD females who are emaciated, small, and they are waiting to get sick, and then they end up using a normal male donor, where obviously the cavity size is shrunken. That all adds to the complexity. And once a few cases it was noticed that it's not doing well, so it is by default not done. Even if everything is good, like you achieve hemostasis, your graft function is good, you don't need any ECMO or anything. Also, it will be shifted with open chest because the lung size is big. So a day or two, you see the lung will get a bit shrunken, and that you'll be able to close that.
Okay, so do you cover it with IOBAN and
Yes, nicely put Gamzipad over it and then cover it with IOBAN fully. Nicely, so that no part.
Some surgeons just only suture the skin and leave it like that, just to not closing the rib cage.
That is
doesn't cause
yes,
any tamponade, sir.
So that again depends upon like in any other case, how much is your size mismatch, what is the cavity size. To the extreme, in some you have to close everything with a retractor in place. A little better take out the retractor, little better close the skin, leave the other thing, or just keep it open with an IOBAN like that. But this is what it is. I mean, now the threshold for resecting a lobe or anything is quite high. It's not that the moment you see it, you try to size it perfectly and then put it there. No, threshold to reject is quite high. If it is really needed only, then it will be considered. Like last case we have done, there was quite some mismatch was there, but that had to be taken because that man was on ECMO for almost 50 days. He was on ECMO, and his cavity was totally shrunk. If we go by formula, that doesn't seem like a significant mismatch, but practically you see, even if you open at the nipple level also, it was all diaphragm with the cavity. Hello.
Yeah. Any question? Any further?
So do you routinely do a on ECMO, or is it like an elective?
Thanks, dear brother. Can you please say again?
Yeah, so no, I just wanted to know if you go on elective ECMO in all the transplants, or you just see how your PA pressures and your
Most of them on ECMO. Most of them on ECMO. CPB only if really required, if there is a pressing need. ECMO plus cell saver is the default thing. Only thing I could see the difference is we go for a blocker. DLT we don't use. We go for a bronchial blocker. The easy blocker is a very good one, easy to place it. We just put a regular ET tube with a subglottic suction and try to put the tube a little higher. Typically 20 or 21 centimeters, and then put a bronchial blocker and you isolate that lung or whatever the surgeon tries to dissect out before the suction part.
No, so
And once anastomosis.
how is that an advantage when compared to a DLT?
DLT, your main advantage will be you'll be able to suck out the secretions. That's the main advantage with DLT. With bronchial blocker, your lumen size will be bigger in the sense that DLT, your airway pressures will always be higher. The lumen size of a DLT is always, so the inner diameter part of it is always smaller. That's the main advantage. And second, this you can quickly alternate and then do it. Some of them, if they don't need anything also, you can just leave it like that. The blocker is the preferred.
But you have no issues of misplacement or movement of the bronchial blocker, sir?
This easy blocker you have seen, no? If you just go by that old blockers and blockers and all, they'll get displaced. This
Okay.
easy blocker has that Y and it sits in the carotid.
We are having it, but one thing is we don't ventilate the lung once it's implanted, like single lung ventilation you don't do post-op immediately on the ECMO. Generally, what we do is we start ventilating low tidal volume once.
One lung. Okay. No, usually, no.
Okay. Because we so that the lung starts getting perfusion as well as
Yes.
No, that's what I mentioned. So usually we start with low tidal volumes.
Yes. I saw that.
So
But even then, it will not be so fluxed with the bronchial anastomosis. I think there'll be some space. Because the isolation by default we do is the blocker. DLT, I don't remember doing anything of late. Blocker is the one what we use for isolation.
so
And usually
the first lung, sir, once you're done with first
that's what. See, I mean, I don't know, but if I can, if I have to just think and answer this, the tip of your bronchial blocker, I think still there'll be adequate room. Distal to the, suppose, let me say the right anastomosis is done and left they're doing dissection, you want to ventilate the right. So you have already deflated the right side, the cuff there.
Yeah.
You have deflated the right side cuff and your left side is the one which is inflated. So that should not interfere with your ventilation. Again, it's just think and tell. We have not done this like this.
So you ventilate once both the lungs are implanted.
Yes.
Okay.
So
we can really we'll start doing it, like we have it. The easy blocker we have, definitely we have it. But only thing is, like we have experts here to put a DLT. We don't say that, but we are just putting it. That's it. Nothing else.
No, DLT is also certainly good. There's nothing against that. But replace as its practice.
Having a help in induction of a lung transplant, patient, it's really a God's real gift for us.
only one more thing. So once you are on Vimi ECMO and you reperfuse your first lung, do you go down on your ECMO flows? Or do you go up on your ECMO flows? How did you handle the reperfusion? When
you gradually reperfuse. Second, you make sure your PA line has ejections. It's not a flat line. You have some flow to the lungs. And on the other side, you don't that you keep it as minimum as possible if you're partially reperfusion, as minimum as possible, just to have some ejections there in the
so you come down on your Vimi ECMO flows, right?
Vimi ECMO flows, that is when you are loading. Usually we come off only once both the anastomosis are done. But that's how we support. We support electively for half an hour to 45 minutes and then start loading. Even that half an hour also, we so that because lung bronchial circulation blocks only flow that lung gets through the PA. So you don't go for a total VA ECMO, totally draining of the blood from the pulmonary circulation. You even if some vent was there, that vent will be off or vent will be titrated, but there are some indications in the PA catheter, as you see in the monitor. Keeping the close watch, that means pressure never shoots up. We keep it only a minimal ejection at the top.
Yeah.
Maybe anything else?
No, sir. Now I think now we're almost at time. So now I think we can close it.
Can you conclude?
Yes.
Yeah, I thank the speaker Vikram for giving a wonderful, concise speech on the lung transplant. I also thank Murali sir for coming all the way and spending 1 hour time with our lung transplant team. We have learned a lot from you. Thanks a lot, sir. Thank you so much for coming and chairing the session and as a moderator. Thanks a lot, sir.
Thank you, Murali sir, for taking some time and giving some valuable information from your side, sir. Thank you very much.
Thank you, Vikram. Thank you, Bala sir. Thank you, Vimi sir.
Thank
Thank
you.
you.
Okay, thanks.